Good afternoon, everyone. Uh, I thank the organizers for having me here and thank Dr. Sahu for conducting the panel very well. And he was talking about this particular uh, abstract not being spoken, and that was me who I got a little bit late. So I'm talking about this Unite study, which was presented by Dr. Nizam in ASCO GU 2024, and I'm reproducing it over here. One of the sublines is what I'm talking about. We all know about these being the current NCCN guidelines, and current NCCN guidelines do recommend about the cisplatin eligible and ineligible cohort, and the same has been spoken a lot in detail in the panel also, which just ensued. So one has to see that EV302 has actually made it to NCCN version 4 in 2024, which was being spoken in the panel as well, which means that even in patients who are cisplatin eligible, one can do without cisplatin by giving Pembro and EV. So EV is certainly making inroads now coming into the first line as well, which was very much anticipated once EV201 came out, which was post 2 lines therapy. So, but then yes, if we talk about our scenario right now, EV is not available. So we have to speak about cisplatin eligible patients getting cisplatin, and that can also be in two ways. One is gemcitabine cisplatin followed by Avelumab maintenance, which is the Javelin protocol, and the other could certainly be a Checkmate 901, which is Nivolumab gem cis followed by Nivolumab maintenance, both being category 1. In patients who are cisplatin ineligible, certainly again we have the option of EV302, and we have the option of gem card followed by Avelumab maintenance. Nivo for a very valid reason has not been tried with gem carb, and we all know we've seen that in the panel discussion. Now coming to this particular Unite study that I'm talking about, which is an oral presentation in ASCO GU 2024. It was actually based on this particular trial, which is EV301, which is a phase 3 trial of Enfortumab Vedotin versus chemotherapy in the second line, which is in patients who've been previously treated with platinum-based chemotherapy. One has to understand that the PFS was approximately 5.5 months, but importantly, there was no data on how many patients actually went on to receive Avelumab maintenance. The PIs, Dr. Paulus was asked later, and they said that it was about 18%. So it is certainly less than the desired number in especially now when we have the standard of care, which is Avelumab maintenance. So in light of that, when we have EV being used in the second line, and there were most of the patients, more than 80%, who did not actually go on to receive Avelumab maintenance, can we actually in the current scenario use EV confidently is what was actually being talked about in this study. So EV, we all know, is an anti-Nectin-4 antibody drug conjugate. It is approved in first line, second line. We've talked about that. Maintenance Avelumab is approved. These trials, mostly of the EV, have not used Avelumab maintenance. The hypothesis was that if we are using it and seeing it in the retrospective analysis, possibly the outcomes should be similar. So, like I said, multicentric retrospective cohort of 600 odd patients, and one had to see the observed responses and the OS and the PFS in patients who received platinum-based therapy, followed by Avelumab maintenance, and then followed by EV. These are the baseline characteristics. Important to note is that they actually looked at the Belmont risk score as well. And this risk score looks at the liver metastasis, the hemoglobin less than 10, which scores a 1, and the ECOG performance status. So there are 3 scores, the 0 being the minimum. So now if we see about 1/3 of the patients had a score of 1, 1/3 of the patients had a score of 2, and they segregated them into 0 to 1 and more than that. We will see that in a while, and that all actually made a difference. Most of these patients were males. Most of these patients were smokers, Caucasians, and they had a median age of 72 years. Most of these patients had bone metastasis as well. So akin to what we would see in our daily practice. Now, important to note is that the PFS and OS is actually from the start of the Enfortumab Vedotin therapy. And if you look at the PFS, it is about 7 months, which I said in the EV301 was about 5.5 months. So it is almost mirroring what the phase 3 trial told us, where Avelumab maintenance was not given. So one can say with confidence that the PFS of 7 months is certainly not bad. If you look at the median OS, it was 13.3 months. Now, importantly, OS from the start of platinum therapy came out to be 22 months. So again, this we can probably draw conclusions from the other phase 3 trials that we have. If we talk about the Javelin bladder study, or for that matter, EV302 as well, because EV302 calculated OS from the very beginning, and the Javelin study actually calculated all the data set from where the Avelumab maintenance started. So by and large, we do understand that the OS is around that figure, and this was same mirrored in this particular retrospective analysis as well. If we talk about the Belmont risk score, like I said, the 0 to 1 being low risk and 2 to 3 being the high risk, it was evident and very much obvious that patients who had a higher risk had a lesser OS and PFS, and it was statistically significant difference between the two, both in terms of PFS and overall survival. So if we have a patient who's got a lesser or a lower Belmont score, certainly one would be more confident offering this particular approach. So the conclusion based on these outcomes by the PIs was that the advanced urothelial carcinoma should certainly be treated, most of these patients, because one would not have EV in all the regions of the world right now, with gemcitabine and a platinum-based approach followed by Avelumab maintenance. And one should not really think about the fact that EV has in the phase 3 trials is not actually Avelumab maintenance not being used, because here there was a mirroring of what was there in the phase 3 trials in terms of the survival data. The higher Belmont score would certainly mean that there will be worse outcomes with EV, and this data does support that EV can be used in the third line, or for that matter, if you used Avelumab maintenance and there is a progression less than 12 months, then EV can certainly come up after that, because very obviously immunotherapy won't be able to come straight away. Thank you so much.